I have been focused on studying lung disease and particularly studying fibrosis of the lung for over 15 years. And actually some of the initial work that I did as a trainee, as a research fellow, was actually focused on trying to understand lung disease and in particular pulmonary fibrosis from families affected with pulmonary fibrosis. And I don't have to tell you that this is a relevant topic for all of you. So thank you for being here. Thank you for all your contributions to knowledge. The understanding DC is very important for pulmonary fibrosis because we think that a lot of the genetic abnormalities that drive the development of lung fibrosis in DC may be relevant to a broader disease that affects millions of people in the world. So you can go home knowing that you're contributing significantly to the health of mankind, and it's not an exaggeration. So this is where I live. This is the Brigham and Women's Hospital. I think this part of the building was built in 1920 or so. We're in the Longwood area in Boston, if you guys are familiar with the city. And let's see if this works. What I'd like to talk about today, I have 45 minutes and I have 70 slides. And the rule is never have more than one slide per minute when you're a presenter, which means that I'm going to give you a lot of data, a lot of information. I'm a storyteller, so I'm not going to give you data. I'm going to give you stories. And what I'm going to try to do is spike your interest and let you know what we're doing in the broader field of pulmonary fibrosis, and so you can start seeing how that ultimately will affect your families. And it's possible that this is going to be a two-way road. Your families teach us about the pathogenesis of disease, and some of the management successes that we've had in pulmonary fibrosis over the last decades will also translate into diagnostic and therapeutic measures for folks in the room that are affected with disease or who have children who are affected with disease. So I'll very quickly talk about pathogenesis, and there are in this group experts in telomere biology, so I don't really have to tell you that much. You'll learn it from them. I'll tell you about risk factors for developing pulmonary fibrosis. I'll try to tell you a little bit about the natural history of a common form of pulmonary fibrosis and see how that compares with the telomeropathies. I'll talk about classification and clinical presentation, which actually is a relevant discussion because this is an evolving area in telomeropathies. And very important for the audience, I'll talk about the present diagnosis and treatment of pulmonary fibrosis in general. And then I think something that's close to everybody here is what about early detection and how that could potentially change paradigms and change how we go about treating patients who are at high risk of developing pulmonary fibrosis. This is a tremendous area of interest for the NIH, for investigators, and highly relevant, I hope, in the future care of patients who are at risk of developing pulmonary fibrosis. So we have 40 minutes. Let's go quickly. This is for you, so if you have questions, interrupt me. And if you want to wait until the end, or when we have the question panels, we can do that as well. If I'm going way too quick, then stop me and I'll just skip some slides and stick to what I think is most important for all of you. So we've known about scarring of the lung for a very long time. This is Sir William Osler, a Canadian that actually moved to the US and is considered the father of medicine. And when he saw fibrotic lungs in patients who died from this disease, he said this is kind of a stiff liver rather than that soft, compliant organ that he was used to seeing in the lung. And he called it hepatization of the liver. And what you see is a striking change in the architecture of the lung. This is a normal lung. If you actually go to a surgery and you see the lung, it's absolutely beautiful. It's pink, it inflates like a balloon. If you touch it, it's just very, very soft. Whereas a fibrotic lung is more like when you go to the supermarket and you buy that sponge and you've used it for 3 months and you don't have an extra sponge and it's hard, it's really not, it's not nice to use. And so this is what a fibrotic lung feels like, and this is how it looks like. All these holes here is what we call structural remodeling of the lung. And this is a real picture of a fibrotic lung. So the tissue that is in charge of gas exchange has been replaced for scar or spaces that actually don't help in gas exchange. And over the last decades, probably the last 3 decades, we've made tremendous progress in understanding mechanisms that may be driving fibrosis. And the take-home message for the audience today is that there's not a mechanism that drives fibrosis. There are multiple contributors that ultimately lead to the development of fibrosis, and in this review paper what we did is we kind of created cartoons for each one of them. And so this protease balance or inflammation, cell death, some mechanisms of disease like autophagy, the progression or the replication of cells that are normally in the lung but at not very high numbers like fibroblasts, and how they are transformed into more matrix producing cells, problems with coagulation, exposures to certain drugs, environmental exposures, which is very important because smoking is tightly linked to the development of lung disease in the adult. Aging seems to be very important and very relevant to all the discussions that you'll have over this weekend. Oxidant balance, there's certain type of cellular defense mechanisms like inflammasome activation that actually may contribute to fibrosis as well. And a biggie in fibrosis, which is ER stress. And some of these actually have been directly linked to the development of telomeropathies. So some of these abnormalities in sequence in telomeres can actually trigger some of the signaling pathways that ultimately lead to the development of fibrosis. And I won't spend a lot of time going into the specifics of what these mechanisms are because they're complicated and boring, but suffice to say that some of the cutting edge research that has occurred over the last 10 years is now pairing into this paradigm of DNA damage and how DNA damage that may be related to these telomere abnormalities ultimately activate these stress pathways that lead to the development of fibrosis. So from a mechanistic perspective, the conclusion is that there's a direct link from what we know about fibrosis in general from what we're learning upstream from these telomere abnormalities that you have been discussing this week. And this is very important because that means some of the strategies that we use to diagnose or treat this disease are relevant to DC as well, or at least that's what we think. So what are the risk factors? Clearly, if you are looking at the majority of patients with adult pulmonary fibrosis, it's very uncommon to have an idiopathic form of pulmonary fibrosis if you're less than 60 years of age. Very uncommon. If a patient walks into my office and they're younger than 60, the first thing I'm thinking, is this a genetic disorder? Because that's the exception. In genetic disorders, there's an extra contribution from your genome that's probably making you more susceptible to the development of fibrosis, and you've probably heard this term anticipation in telomeropathies, which is you can actually see this disease appear earlier and earlier as generations go by. So aging is a critical component of this disease from an epidemiologic perspective in adults, but it actually teaches, telomeropathies have taught us about why this characteristic of aging in adult pulmonary fibrosis is important. It's probably because at a molecular level, telomeres are important in the aging of cells, and the aging of organs, and in the aging of an individual. So I think that makes sense. Male gender, we don't understand it very well. But you know, something that immediately comes to mind is this story about using androgens and how androgens may be important for preserving telomere length, and maybe a therapy in the future for patients who have telomeropathies. And a big one here, it seems like this is a disease that almost in everybody is a gene by environment disease, okay? So you may have a true genetic abnormality like we see in patients with DC, or you may have a variation in the genetic sequence that for sometimes reasons that are not very clear make you more susceptible to the development of pulmonary fibrosis. But some of these that are not highly penetrant require an extra stimulus from the environment to be able to lead to disease. And because the lung is an organ that's so highly exposed to particles, smoking or particles that come from other activities are probably an important contributor to damage in the lung. When you're young and you don't have disease, you can walk through an area that has a lot of pollution, and you probably have damage to the lung, but your ability to repair the lung is extremely robust, and for this reason you don't develop disease. But maybe when you hit the age of 60, or you have a genetic abnormality, walking through that same street that is highly polluted will lead to injury that then leads to aberrant repair and fibrosis. So it's critical to understand that environmental exposures may be the trigger that's necessary for the development of the disease. And clearly from a statistical perspective, there's multiple things that can lead to the development of fibrosis that I've listed here, although clearly cigarette smoking is probably the most important cause. There is some evidence that patients who have pulmonary fibrosis have had viral infections in the past. And there's some interesting research actually in families who have pulmonary fibrosis suggesting that some adenovirus can be both detected and quantified in patients who have early stage asymptomatic fibrosis, suggesting that viral infections, again, may be one of these triggers that in concordance or in addition to this genetic abnormality leads to the development of fibrosis. And by this token, you're starting to see a pattern in which anything that can cause injury can potentially lead to the development of fibrosis in susceptible individuals. So you can imagine if you're having gastroesophageal reflux, you're having acid coming from your stomach into your lung, and it's not supposed to be there. This could be a source of chemical injury. And there's some compelling data suggesting that there's an association between having untreated reflux and the development of fibrosis. There's also some additional data suggesting that if you have reflux, you may have worse outcomes. But there's also some data that contradicts this point, because some patients who are actually treated for reflux tend to have worse outcomes than those who are not treated. So the jury is still out regarding the contribution of gastroesophageal reflux. And there's an interesting component to the US population demographics. As you all know, 40% of us are obese. And it seems like metabolic disorders for multiple reasons may be contributors or risk factors for the development of aberrant repair like we see in pulmonary fibrosis. So it's possible that actually this healthy lifestyle that we're asking everybody to have has to do with our ability to actually appropriately respond to injury. So again, this is something that's not as clear as cigarette smoking, but all of these could be potential risk factors for the development of pulmonary fibrosis. So we really focused 30 years ago on a entity that had a very poor prognosis. Okay? If a patient has idiopathic pulmonary fibrosis, then I'm showing you a survival curve, and here I'm showing you 100% survival, and here I'm showing you time. And the take-home message of this was that if you have a diagnosis of idiopathic pulmonary fibrosis and you see me in clinic, in average, the patients have a 5-year survival. Of course, that's a very poor survival. For a 60-year-old, that means that in average, the lifespan will be 65, which is, I think, 10 or 15 years below the average survival of a male or female in the United States. So it's a very important disease. And this very complex slide is just to show you that there's just not one form of pulmonary fibrosis. There are many forms of pulmonary fibrosis. And this classification has changed quite a bit, multiple times. And an easy way to think about this is there are fibrotic lung diseases that are chronic, and I'll show you a little bit about their characteristics. Others that are exclusively smoke-related, and some that are actually more acute or more dramatic. And this is relevant to DC because it seems like these quote-unquote phenotypes can also be found in patients with DC or in patients with familial pulmonary fibrosis. So idiopathic pulmonary fibrosis is the most common entity, and it's age-dependent, as I told you. So if you look at individuals that are 50 years of age, the prevalence is somewhere between 50 to 100,000, 50 individuals per 100,000. But if you look at individuals that are 70 or older, it goes up to 250 per 100,000. So the prevalence clearly increases with age. And there's some characteristics that I'll tell you about in a second that allow us to make a very easily allow us to make a diagnosis of idiopathic pulmonary fibrosis. There are characteristic changes in what we call a CT scan. CT scan is a three-dimensional imaging tool that we use to make the diagnosis of fibrosis. Characteristically, we find lesions in the lower lobes and in the periphery of the lung. And if a lung biopsy is performed, which is very infrequently performed in patients with familial disease, you'll find a characteristic pattern in the histology that I won't get into. So it's very easy for us to actually make a diagnosis of idiopathic pulmonary fibrosis. We recognize these individuals quite well. However, there are some entities that look like idiopathic pulmonary fibrosis that sometimes challenge this diagnosis. A good example of this is nonspecific interstitial pneumonia. And in nonspecific interstitial pneumonia, the pattern, the radiologic pattern, is quite different. It doesn't have the subpleural appearance that I showed you before. And also the histologic pattern is different as well. And I'm not going into the many subtypes of pulmonary fibrosis, which are important to identify because it allows us to provide prognosis for patients with this disease. Now, the reason why I bring this is because there's a very interesting paper from Christine Garcia's group that actually shows that in DC, we also find these different forms of interstitial abnormalities. Okay, so these different patterns. I told you about IPF and NSIP. If you look survival curves of NSIP, it's very different from that from IPF. The survival is much better, and there seems to be more response to steroids. What's interesting about this paper is that regardless of the histologic pattern that you identify in a patient who has pulmonary fibrosis with DC, the outcome resembles that of pulmonary fibrosis. So this is an exception to that kind of rule that we've created in patients with interstitial pneumonia. Very relevant to our discussion today. And if you actually look at the survival curves, I'm going to be asking you to remember that first survival curve, but basically what we see is it doesn't really matter what type of histopathology you have or what type of mutation you have. The survival really resembles that 5 years that I was talking about before. So what does that mean? That regardless of the type of fibrosis that patients with DC have, they tend to be rapidly progressive fibrotic diseases. In contrast to other fibrotic disorders that tend to be some more indolent. So it's a very important point. Now, with that, there are some exceptions. I think part of it is that we're already looking at progressive phenotypes. What I mean by that is that data is probably coming from patients who we already knew were going to progress. So they're all progressing, right? Regardless of their histopathology. So Sohail Shamali in our program, when he was at the NIH, actually showed that he identified 2 sisters that were followed for a period of 30 years. And one of the sisters actually had a progressive phenotype, whereas the other one had just very subtle changes 30 years after the development of the disease. This to say that, I think this suggests, although we're only talking about 2 patients, that if you have early subclinical interstitial lung disease, not everybody is going to progress the same way. So it's a little bit confusing, but suffice to say that if we identify a patient with DC, I think they are at higher risk of progression than the other populations of patients with pulmonary fibrosis that we usually follow. Talk about hepatopulmonary syndrome before he came in. I just wanted to make a parenthesis here because not all lung disease in DC is related to scarring of the lung. Some of the disease actually may be related to shunts, and I think one of our speakers will mention them later. I will not spend too much time on this, as this is not my area of expertise. By the same token, you know, the development of fibrosis not only comes from idiopathic or inflammatory origins, but because many of DC patients actually undergo bone marrow transplantations, pneumonitis and interstitial pneumonitis is not an uncommon complication in patients who undergo bone marrow transplantation, and may be the reason why fibrosis is developed. Now, let me step outside of the realm of DC and let me tell you a little bit about challenges that we have in the field of pulmonary fibrosis. So one of the problems that we have doesn't really have to do with the diagnosis, but has to do with the prediction. So the prediction of the progression of disease. So if a patient comes to my clinic and we can establish a diagnosis, and I already told you that we can do that quite easily, the next question the patient asks is, what's going to happen to me? Over the next couple of years, what is the expectation? And what we've learned over studying thousands of patients with pulmonary fibrosis is that the progression is actually quite variable. Okay? The other thing is related to the phenotypes that I was talking about, the different types of pulmonary fibrosis. So you have the challenge of making the diagnosis, but also you have the challenge of trying to identify what the rate of the progression in these individuals are going to be. So maybe one of the ways to actually go about helping us determine what the diagnosis is, if the patient has a subtype of pulmonary fibrosis that's progressive or not, or to be able to determine what the prognosis of this patient is, may be to actually use molecular tools to help us with it. And this is very relevant because there are clearly sequence abnormalities in patients with DC that over time, as we have more and more numbers, could help us predict which are the variants that are more or less progressive. And that's the backbone of this concept of using personalized medicine to diagnose and treat patients with different conditions. And obviously there's I think it's a $500 million investment that was recently made specifically for cancer, which is also relevant to DC, to actually try to implement personalized medicine approaches for the management of cancer. So what are the potential roles of precision medicine in pulmonary fibrosis? It could work as a molecular classifier and complement this challenge that sometimes we have making the diagnosis of different diseases. Predicting outcomes. So I told you a patient wanted to know how rapidly their disease would progress. So some of these molecular markers can aid in identifying patients who are at higher risk for progression. And as we develop more and more therapies, it may be that specific therapies are relevant to specific conditions, and some of these molecular markers may help us stratify what patients may actually be treated better with one medication or another. And in the case of the genetic abnormalities associated to pulmonary fibrosis, more and more we're finding both rare and common variants that actually may be associated with the development of the disease, but also have the ability to predict some of these outcomes. So the list of genes continues to, you can't really see it here, but the list of genes was very small 20 years ago. We only had the surfactant proteins. Now some of the telomere genes are part of this list, and we're learning more and more about the different genetic abnormalities that are associated with this development of the disease. And as I said before, these in some way could be actually used as predictive tools. And what we started to do at the Brigham is to try to collect that information. We're not actually using it right now, but we're starting to collect this information because we expect that this will become relevant for the care of patients with genetically driven fibrotic disorders in the future. And so this is Benjamin Raby and other collaborators at the Brigham. If I see a patient with pulmonary fibrosis and I suspect that there's a genetic abnormality, I will refer the patient to Benji, and Benji with his team will do a formal evaluation with what we call pulmogene sequencing panel that focuses on previously identified genetic variants that are associated with the development of lung diseases like pulmonary fibrosis. And we'll try to identify these genetic traits, and both for clinical purposes, which I'll share with you in a second, or for research purposes, we're collecting both this data and all the exon sequencing that's performed if patients are willing to participate in the research studies. So there's integrated care in our clinics trying to address some of the genetic disorders associated with pulmonary fibrosis. Another way of actually using some of the what we call genomic approaches is to actually use peripheral blood signatures or tissue signatures that will allow us to make a diagnosis. So I told you that sometimes we have a challenge in diagnosing patients with idiopathic pulmonary fibrosis or other forms of fibrosis. And in this study, what they were able to show is in a derivation set of individuals who had pulmonary fibrosis, these are gene expression analysis from lung tissue, they were able to derive a signature that had a fairly impressive ability to identify patients with idiopathic pulmonary fibrosis. And they went on to use this training set to validate in an independent set of samples, test to see if the criteria that were used here to distinguish patients with IPF and non-IPF, to see if they could use that same signature to prospectively identify patients who had a diagnosis. And the answer is you can, with a fairly robust sensitivity and specificity, suggesting that in the future we may be able to use these signatures to make a diagnosis. Now these are tissue signatures, which means you need a biopsy, but there's also the ability to do something similar to this with peripheral blood samples. And so I think this may be a tool that will be very useful in the future. As an example of this, if you actually take a panel of proteins in the blood, you can actually measure these. It's a non-invasive procedure. You can use these protein panels, and I won't go into detail about this experiment, but we used 50 proteins to see if we could distinguish IPF from other conditions. And it seems like this peripheral blood protein signature could be used in the future as a diagnostic tool. It's now evolved into other studies that I'm not going to go into right now. So in terms of diagnosing the specific forms of pulmonary fibrosis, I think we'll be able to use these molecular tools. The second challenge I've already mentioned, which is that we don't really know who's going to remain stable or who's going to progress over time. And again, the use of molecular signatures may be useful for this. And so this is a paper from Christine Garcia's group in which she actually measured the telomere length, and I'm pretty sure most of you know what the telomere length is. And basically from the peripheral blood, she was able to stratify patients who would have better or worse prognosis in terms of their pulmonary fibrosis. So it's possible that we're going to be able to use the telomere phenotype in the peripheral blood to identify patients who are at higher risk of progression, patients who we either have to refer earlier to transplant, or patients who down the line, when we have robust armamentarium medications may benefit from one therapy or another. And this, actually, this was the follow-up data that I was going to show you. The same thing can be actually done with phenotypes in the peripheral blood. So that same signature that we had previously identified can also predict the different types of progression in patients with pulmonary fibrosis. Another example of this is not using soluble proteins or genes, but actually using gene expression of peripheral blood mononuclear cells. This study was actually done in the University of Pittsburgh. If you used a certain gene expression signature, you could see that there was a difference in the progression of disease in 2 different groups, and this was independently validated in our cohort. This has been on now to validated in 6 independent cohorts, suggesting that you could take peripheral blood, do gene expression signatures, and be able to predict who's going to have rapid or slow progression. So let's talk a little bit about, let's switch gears and talk a little bit about treatments. I think that it's clear from what I've said to this point that we have robust clinical tools to make a diagnosis. We have a growing armamentarium of molecular tools to try to define prognosis. But what's really important right now is that we are able to take some of the knowledge that we have gained over the last 3 decades regarding mechanisms of disease and some of this knowledge regarding the phenotype or the progression of disease to be able to effectively treat patients. And so I had mentioned before that one of the characteristics of this disease is that there are multiple contributors to the development of the disease. So here are some examples. Clotting and coagulation may contribute. Inflammation may contribute. Fibroblast biology may contribute, and the extracellular matrix. All different elements coming from different biological pathways may be contributing to the development of the disease. And based on that paradigm, different targets have been identified, and different treatment regimens are being developed at this time. And so they target some of these biological processes that I'm mentioning. And this is important because, like with cancer, it's possible that the most effective way of treating pulmonary fibrosis is not single therapy. It may be that we need multiple medications that are attacking different mechanisms to be able to effectively treat fibrosis. And so this is a slide that actually tries to graphically represent. You guys hear me? Hello? I think I lost volume here. I'll scream. So this is a slide that graphically tries to represent what we've done in clinical trials in pulmonary fibrosis over the last 10 to 15 years. And since the year 2000, what you see is that we used to do very small trials, and now we actually do very large trials. And so we've learned a lot about how we have to design these trials, and I won't go into detail, but the endpoint or the measurement that you use to determine if a treatment is efficacious or not continues to be a challenge in the area of pulmonary fibrosis. Now, the good news is that after 15 years of having multiple trials that actually were not effective in pulmonary fibrosis, we now have effective therapies. And of course, these are relevant to patients with DC because many patients right now with DC who have pulmonary fibrosis are eligible to receive this treatment. And so this is a slide that basically shows the results of 2 clinical trials that were published in May of 2014 that demonstrated that antifibrotics, the antifibrotics that we're talking about are pirfenidone and nintedanib, can actually reduce the rate of decline. So if you use a measure of lung function and time, you can see that patients with pulmonary fibrosis who are not on therapy actually have a certain rate of decline. And this is for the pirfenidone trial. Similarly, for the nintedanib trial, if you're looking at lung function and time, you see that the placebo arm or the patients who did not receive therapy have a certain rate of decline. Somewhere around 200 mLs per year is the loss of lung function for a patient with pulmonary fibrosis, which is actually quite remarkable because in normal individuals we should be seeing less, much less than that, less than 50 or even less than. So what happens if you give these patients therapy? What happens if you give them pirfenidone? And what you actually see is that the rate of decline is actually reduced, okay, for both medications. So this actually led 4-6 months later to fast-track approval by the FDA for antifibrotics and IPF. And that's basically groundbreaking because, as I said before, we've been doing research in this area for 30 years and we still had not developed any therapies. So this was a really important step forward, but if you think about it, and you're not thinking about it, but I'll do the math for you, it's really not going to dramatically change the survival, and more importantly, there's no evidence that these treatments are actually changing the quality of life in patients affected with pulmonary fibrosis. So it's a good start, but we definitely need to improve. And as I said before, it may be that single therapies are not going to be able to take us where we want to be, which is to stabilize disease and make this a chronic condition. The other thing that we learned is that for 30 years we had been treating patients with anti-inflammatories. So for many years we gave patients with pulmonary fibrosis prednisone or prednisone equivalents. And what this study, which was actually published a couple of years before, demonstrated is that immune suppressive therapy in patients with pulmonary fibrosis may be harmful. And without doubt, in patients with IPF should not be administered. So in a matter of 2 years, with some work that took a couple of decades, we were able to do two things. One, demonstrate that something that we had been doing for a very long time was actually not helpful, but potentially harmful. And the second thing is we made the first step to effectively treat pulmonary fibrosis in patients with IPF. Now, these medical therapies for DC may be just as relevant because, as I said before, these telomeropathies or these genetic abnormalities that lead to telomere biology disorders may have the same outcome in terms of the development or in terms of the aberrant cellular responses that lead to fibrosis. We don't really know what causes IPF. We have some genetic associations, including some telomere genes, but we truly don't know what the cause of IPF is. We do know, or we think we know, what the cause of pulmonary fibrosis in patients with DC is. But again, the genetic abnormalities may be different in different conditions, but the outcome, fibrosis, may be treatable in both. But a specific therapy that many of you may know about is actually the treatment of the use of Danazol. And this phase 1, phase 2 trial that was done in the NIH by Neil Young's group suggests that androgens may be able to elongate telomeres. And that elongation of telomeres, which was statistically significant, was associated with important clinical, or change in important clinical endpoints, like potentially a decrease in the density of FibroScan, which is a measure of liver fibrosis. And so it's possible that medical therapies that have not been used in IPF may be developed for DC, and this may be one of the therapies that we use in conjunction with antifibrotics or other medications that are coming down the pike. So I think the good news is that there's some light at the end of the tunnel for patients who have DC and fibrosis, because in general, we're identifying therapies that may be relevant to the development of fibrosis from these genetic disorders, and at the same time, it could be that there are some therapies that right now are modifying the cause of the disease by preserving telomere length, and therefore may be affecting the progression of pulmonary fibrosis in patients with DC. What's very clear is that despite the fact that we've developed medical therapies, we are not significantly improving survival in patients with pulmonary fibrosis. Maybe we're providing another year or two and providing some time to bridge patients to transplant. Okay, and so transplant's been around for 30 years as well. I think the first transplant was done in Germany in 1985 or so. And since 1992, we've been able to do technically much better in lung transplantation. And right now, our survivals at the first year are fantastic, above 95%. And our survivals for 5 years, unfortunately, not what we want them to be, but they're somewhere around 50%. So for a patient who actually doesn't have or who has not responded to medical therapy, lung transplantation continues to be a very important option. And this is a slide actually showing survival of patients with IPF, pulmonary fibrosis, or COPD, a less common form of lung disease in patients with DC. And what you see from these graphs is basically there seems to be a difference between having a single or a double lung transplant. You can't always have a double, but if you can have a double, it seems like it is a better, especially for younger people, it's better to have a double lung transplant. And again, showing that more or less the survivals are somewhere around 5 to 6 years after lung transplantation. And we can get into the discussion of why survivals are not greater than that, but despite the improvement and the technical aspects of transplant and optimization of immune suppression, that unfortunately is the survival. And I think it has to do with the fact that the lung is exposed to the environment. right? There continues to be this particle burden and other aspects related to breathing that probably lead to the development of rejection, and why we have such different outcomes compared to liver or heart, which are not exposed as much to the environment. Now, so do patients with DC do well with transplant? And I'm going to show 3 or 4 slides about this, but I'll give you the punchline right now. We don't know. I can tell you that it seems intuitive, and some of the small series suggest that if you have significant thrombocytopenias or cytopenias prior to transplant, you're going to get into trouble. And that makes sense, right? Because if you have low platelets, and platelets are important for coagulation, you're going to get into trouble. But in addition to that, remember these cytopenias lead to the significant lowering of cell counts that may be important in transplant patients in terms of the development of infectious complications. Again, I won't go into the details of these papers. The bottom line is it seems like these cytopenias may be a red flag when a patient with DC is being transplanted. For less clear reasons, there seems to be other organ dysfunction more commonly in patients with DC than we see in the regular transplant population. And in this case series, for example, they were reporting that there was a higher incidence of renal insufficiency, and there was a higher incidence of colitis associated to one of the immune suppressants. And the actual cause for this, I'm not an expert in this area, so I won't dare speculate, but it seems like for these reports that it's not very clear why these patients actually end up developing these complications. So I think the bottom line is that not every patient with DC will be able to have a successful lung transplant, and there seems to be some hint that some particular organs may be at higher risk than the normal transplant population. In our transplant program, basically this is all case-by-case basis. We're trying to push the envelope as much as we can and try to evaluate patients and safely offer this possibility of lung transplantation. And similarly, this is another manuscript that actually lists, I think it's 14 patients, and talks about the development of acute rejection and does a comparison between the acute rejection in these 14 patients who were transplanted with DC and the other overall general transplant population. And there also seems to be a hint that the prevalence of rejection in the lung transplant population could be different in DC than in other subjects. But we're talking about 14 patients. The other case series was 9 patients. And clearly this is not a sufficient amount of evidence to make any definitive statement regarding the adequacy of transplant in the DC population. So I think, again, in our program, I can't speak for others, we really try to evaluate risk prior to the development, prior to leading patients to transplant. And this is a pilot study that was led by Sohail Shamali. And basically what we were trying to see is some of the features that patients have when they walk into our transplant clinic may be predictive of a poor outcome. And I won't make it very complicated. We were looking at MCV and other criteria to see if there was evidence or a phenotype that would suggest a significant telomeropathy. And the conclusion to this, and a follow-up paper that we have, is that we really don't know. And we didn't conclude that patients with DC or other telomeropathies should not have transplantation. Rather, we insist that patients have to be evaluated on a case-by-case basis. If we identify something that we suspect could be an additional risk factor for the outcome of the transplant, we have to have a very honest discussion with the patient regarding the adequacy or the candidacy adequacy. So I'm done, right? My time ran out, or do I have 5 minutes? This is a first. Say that again?
I said this is a first. Thank you. It is time, but certainly if you feel like you'd like to hit on any more.
No, so I'll just take 1 minute saying this.
Sure.
It seems that the best way to go about understanding disease from what we've already learned and I already described is that we better understand what the early stages of disease are. And it's not only interesting, it's also compelling because it's possible that the amount of fibrosis that we have to treat is less. And it's possible that instituting therapies that would allow for chronic care like we see in diabetes or in heart failure would be much more feasible if we actually prevented disease. And so I have a ton of slides here that I'm just going to skip. And I'm going to take you to the bottom line. Now, this is a slide, it's kind of a cartoon that I made up. And this is what coronary artery disease used to look at when Netter, he's a very famous artist, and actually made these cartoons for medical books. So Netter used to show this man who's actually out in the snow, either shoveling or he's out in the snow and he's having a heart attack. And back then, we thought what happened was there was a clot that occluded a major coronary artery and this patient died from a heart attack. And right now, that's where we are with pulmonary fibrosis. We're 30 years behind. Okay, we're still thinking about the heart attack. We're still waiting for patients to come to the clinic with shortness of breath, of cough, and the use of oxygen. When I see them at that stage, they have very advanced fibrosis, and the next clinic they're going is going to the transplant clinic. So the dream here is would it be possible, like what happened with cardiovascular disease, that we could detect this disease at an earlier stage? And I'm putting, again, this is a speculation, but I'm putting cartoons of what the paradigms used to be. This used to be the paradigm of Netter, which is you had a total occlusion of the coronary artery, and that led to death of the heart. That's how we thought about a heart attack. It turns out it doesn't work like that. You can have an 80% occlusion and have absolutely no problems. And you can have a 10% or 20% abnormality and have a heart attack. And the reason for this is because the cause of the heart attack is something that we call endothelial dysfunction. It doesn't have to do all with the anatomic abnormality. And I think this is the same place we are with pulmonary fibrosis, which is we're waiting here for the heart attack. When the patient arrives to my clinic complaining of cough and shortness of breath, the game is over. The game started 20 years ago based on some of the evidence that we have, and I didn't have a chance to show you the data, but we've done this in patients, in smokers, in older individuals, in patients with rheumatoid arthritis, and in families affected with pulmonary fibrosis. And without question, we can detect this disease at a very early stage. And what's really interesting, and this is a study from Vanderbilt, is that these phenotypes, these early phenotypes, are associated with something like a viral infection. So again, this is a huge speculation. But imagine that we would be able to detect patients 30 years before the development of fibrosis, and they had a viral infection, and we gave them something as simple as a cyclovir. And we were able to prevent the progression of the disease. It's probably not true, but as a paradigm, it really raises the possibility that particularly in patients who are at risk for developing pulmonary fibrosis, like patients with DC, we have to be very proactive in detecting the disease at an early stage. And now that we have more medications coming down the pike, think about how we could affect the course of the disease early on, rather than waiting that the disease has progressed to a stage in which we need a transplant. I'm going to leave it there. And I think we have questions later, right?